Welcome back to the Vital Signpost. Today we're tackling a topic that's essential for us nurses.
Anesthesia.
Anesthesia. Oh, it's so fascinating.
hmm
And complex, too. The meds, the techniques, everything's come a long way. As nurses, we got to have a rock-solid understanding of it to keep our patients safe and give them the best care possible.
You got that right. Whether you're like a seasoned pro or you're just starting out, this deep dive is all about helping you grasp the essentials. I mean, those nursing textbooks, let's be honest, they can be a bit much sometimes. So we're here to break down the most important info from your anesthesia chapter, make it stick.
We'll cover a whole range of stuff, the different types of anesthesia, how they work,
Yeah.
the risks, the complications, and most importantly, how you can actually use this knowledge to put together a solid nursing care plan for your patients. So to kick things off, why don't we take a look at those 7 key objectives from the textbook chapter. Think of them like a roadmap for today. First up, defining anesthesia. What does it even mean, right? Sounds simple, but there's more to it than you'd think.
Then we'll really get into the different types. We'll explore general, local, and then there's this thing called monitored anesthesia care, or MACA as it's often called. Each one's got its own quirks, its own uses, and its own potential hiccups, so we'll break all that down.
Objective number 3. We're getting into the nitty-gritty, most common anesthetic drugs in each category. And, importantly, the risks and the nasty side effects that can come with them. Got to know both sides of the coin.
Next up, we tackle a special group of drugs used during general anesthesia. Neuromuscular blocking drugs, NMBDs if you want to be fancy, powerful stuff. These meds paralyze muscles, even the ones we need to breathe. So we'll talk about how they work, the different types, and the super important safety stuff you got to keep in mind.
Objective number 5 wants us to compare and contrast. General and local anesthetics. Oh, and the drugs we use for moderate sedation. It's that middle ground, not totally awake, not completely under. We'll talk about how they work, when we use them, what kind of side effects they can have, how they're given, and who's a good candidate for each type.
Then we get to the practical stuff. Objective 6 guides us through creating a nursing care plan for patients before, during, and after general anesthesia. That's your framework for delivering holistic, patient-centered care throughout the entire surgical experience.
And last but not least, Objective 7. We're crafting a care plan specifically for patients getting local anesthesia or moderate sedation. Got to remember, those require a slightly different approach, different monitoring strategies.
Lots to cover, right? But by the end, you'll have a solid foundation about all things anesthesia, ready to give your patients safe, compassionate care.
Before we get lost in the weeds, though, let's define a few key terms that are going to pop up a lot.
Absolutely. Clear definitions, that's the foundation for understanding anything, especially something as tricky as anesthesia. So let's start with anesthesia itself. What are we really talking about when we say that word?
Anesthesia, at its core, it's all about a controlled, temporary loss of sensation or awareness.
Yeah.
Could be numbing a tiny part of the body, or it could be making you totally unconscious.
Depends on the type of anesthesia we're using and what we're trying to achieve with the procedure.
Exactly. And this whole state of anesthesia, we achieve it with these meds called, anesthetics. They work on the nervous system, block pain signals, and mess with consciousness.
So the anesthetics are the tools, and anesthesia is what happens because of them. Let's unpack those different types from your textbook. We'll start with the big one, general anesthesia.
General anesthesia, that's what most people think is when they hear anesthesia, right? Lights out, completely unaware of what's going on, can't feel a thing. And it's important to remember, general anesthesia, it messes with your reflexes too, even breathing on your own. That's why folks under general anesthesia always need to be on a ventilator. Got to make sure they get enough oxygen during the whole thing.
Exactly. The drugs for general anesthesia, we can give them through the IV or have the patient breathe them in as gases. They basically, they put the brain to sleep for a bit. Temporarily, of course, and it's reversible.
Now, let's flip the script and talk about local anesthesia. Much more targeted approach here.
Local, we're just trying to numb a specific spot, keep the patient wide awake. We do this by injecting a local anesthetic right near the nerves that gives sensation to that area.
So it's good for stuff where you don't need to knock the patient out completely.
Right.
Stitching up a cut, doing a biopsy, even some dental work.
And since it doesn't touch consciousness or breathing, local is often seen as a safer option for certain patients and procedures.
Now, you mentioned monitored anesthesia care earlier, MAC. Where does that fit in?
MA, it's like a hybrid. Mixes a little general with a little local. We give the patient meds through the IV, sedatives and pain relievers, to chill them out, but they don't go completely unconscious.
So they're awake, but relaxed, maybe even a bit sleepy.
Yep, that's it. They're conscious and breathing on their own, so EMA is often a good choice when the procedure's quick and you don't need the muscles to be totally relaxed.
Sounds like a happy medium for people who get a little freaked out about general anesthesia.
Right on. Balance of comfort and safety. It's getting more popular these days for all sorts of procedures.
All right, let's dive into a few more key terms from the textbook. We'll start with adjunct anesthetics.
Adjunct anesthetics, these are meds that aren't the primary anesthetic, but we give them alongside the main event.
Hmm.
They boost the effects, manage side effects, or just help keep things stable. Think of them as the supporting cast.
Like the sidekicks that help the main anesthetics do their job better.
Perfect analogy. For example, muscle relaxants. Those are common adjuncts. Help with putting in a breathing tube or keeping the patient still during surgery.
Balanced anesthesia, that's another term you'll see. What's the deal with that one?
Balanced anesthesia, that's all about using a mix of different anesthetics from different drug classes. Instead of just relying on one drug, we create a custom blend tailored to the patient and the surgery.
Like a special cocktail.
That's the idea. This way, anesthesiologists can really fine-tune the experience, target specific things like pain relief, sedation, muscle relaxation, even amnesia, while keeping the side effects to a minimum.
All right, now for the term no nurse ever wants to hear in the OR, malignant hyperthermia. That's got to be serious.
It is seriously serious. Malignant hyperthermia, it's rare, but it can be deadly. It's an inherited thing triggered by certain anesthetic meds,
Right.
especially some of those inhaled anesthetics and a muscle relaxant called succinylcholine. Basically, the body temperature spikes out of control, muscles go rigid, and a whole cascade of metabolic mayhem ensues.
So not everyone is susceptible, but for those who are, it's a real danger.
That's why it's so important to know the signs and symptoms, catch it early, and act fast if it happens.
Absolutely. Now that we've got those terms down, let's dig a little deeper into how general anesthesia actually works. What's going on in the cells to make someone unconscious?
General anesthetics, they mainly mess with how nerve impulses travel in the central nervous system. That's the brain and spinal cord. Basically, they disrupt the communication between nerve cells, stop those signals from reaching the brain, and bam, anesthesia.
So like cutting off the communication lines.
You got it. The exact way they do it depends on the specific drug, but the goal is always the same. Mess with neuronal activity, lead to unconsciousness, no pain, and relaxed muscles.
You know, one thing that always gets me about anesthesia is how it doesn't hit all parts of the brain at the same time. There's a specific order to it.
You're right. It's like a well-rehearsed play. First, you lose your senses. Sight goes first. Then touch, taste, smell, and finally, hearing. Then consciousness starts to fade as the parts of the brain responsible for awareness get shut down one by one.
And the really interesting thing is the vital functions, the ones controlled by the brainstem, like breathing and heart rate, they're usually the last to go.
That's why we watch those like a hawk during anesthesia. They're the last to go, but they're also the most important for keeping the patient alive.
The textbook mentions this Overton-Meyer theory when it's talking about how potent different anesthetics are. Can you break that down for us?
Overton-Meyer theory, also called the lipid theory of anesthesia, basically says that how potent an anesthetic is depends on how well it dissolves in fats, or lipids. Simpler terms, the more fat-soluble it is, the easier it can get into nerve cells, because those cell membranes are packed with lipids.
Like a key fitting into a lock. The better the anesthetic sits into that fatty environment, the better it can disrupt nerve signals and create anesthesia.
Right on. This theory helps explain why some anesthetics pack a punch, even at tiny doses.
Now, you'd think stronger is always better, but why don't we just use the strongest anesthetics all the time?
Well, medicine's all about balance, isn't it? Those super potent anesthetics, they tend to hang around longer, take more time to wear off, and they might come with a whole bunch of nasty side effects.
So it's about finding that sweet spot, an anesthetic that's effective for the specific surgery, but won't cause a ton of problems.
You got it. Choosing the right anesthetic, it depends on so many things. What kind of surgery, how long it'll take, the patient's age and health, any other conditions they have, and their individual tolerance and risk factors.
Sounds like a very personalized decision.
It is. That's why those preoperative assessments are so important. And everyone needs to be on the same page, the anesthesiologist, the surgeon, and the nursing team.
Our textbook mentions that the old stages of anesthesia, the way they used to describe how the effects unfolded, aren't really relevant anymore.
That's true. Back in the day, when the drugs were slower and less predictable, doctors would watch for these distinct stages as the patient went from awake to unconscious. They'd look for changes in the pupils, breathing patterns, reflexes, things like that.
Like a step-by-step process you could actually see.
Exactly. But nowadays, with our fancy new drugs and monitoring tech, we have much better control over how deep the anesthesia is and how long it lasts. The drugs work faster, and we can adjust them more precisely to keep the patient stable.
So those old stages aren't as clear anymore, and we rely more on continuous monitoring, those vital signs, and other physiological parameters.
Absolutely. Shows how far we've come in terms of safety and predictability.
Okay, so general anesthesia is great and all, but it can affect different body systems, and we got to keep a close eye on those effects.
You're right. It's not just the brain that's affected. General anesthesia can really impact the cardiovascular system, respiratory system, liver, kidneys, even the central nervous system beyond just consciousness.
It's a lot more than just putting someone to sleep. We're managing all these systemic effects and making sure their vital functions stay stable the whole time.
Exactly. Let's start with the respiratory system.
So, general anesthetics, they suppress breathing, right?
Mm.
By messing with those respiratory centers in the brainstem. This can lead to slower breathing, shallower breaths, even periods of apnea where they stop breathing altogether.
Which is why mechanical ventilation is non-negotiable during general anesthesia. We take over their breathing for them, make sure they're getting enough oxygen and getting rid of that carbon dioxide.
Without that, they'd be in big trouble.
Big trouble indeed. Now, moving on to the cardiovascular system. General anesthetics can also do a number on blood pressure and heart rate. They can cause vasodilation. That means the blood vessels relax and widen, which can drop the blood pressure.
And this is extra important to consider for patients who already have heart problems, like high blood pressure or heart disease.
Absolutely. We got to be super careful with monitoring and adjusting the anesthesia to keep their cardiovascular system stable.
What about the other organs, like the liver and kidneys?
General anesthetics can decrease blood flow to those guys. And they're important. They filter and metabolize all the meds and waste products in the body, so their function can take a temporary hit, especially in patients who already have liver or kidney problems.
So it's like those organs are taking a break while the body focuses on getting through the surgery.
Good way to think about it. We always check their liver and kidney function before and after surgery to see if the anesthesia had any impact.
What about the central nervous system? We know general anesthesia knocks people out, but are there any other neurological effects we should be aware of?
Sometimes, yeah. General anesthetics can cause some temporary neurological weirdness. Things like blurry vision, their eyes might move around involuntarily, even changes in pressure inside the brain.
So even though it's generally safe, we got to watch those vital signs and organ function the whole time.
Absolutely. And that monitoring doesn't stop when the surgery's over. We got to be just as attentive in the post-anesthesia period, make sure they recover smoothly and without any hiccups.
Speaking of recovery, the textbook talks about special considerations for older folks going under anesthesia.
It does. As we age, our organs don't work quite as well, and that can really change how older adults respond to anesthesia and how their bodies process those meds.
So it's not just about what kind of anesthetic we use. We got to be really careful with the dose and how we monitor them based on their age and overall health.
Exactly. Older adults are also more likely to have a bunch of other health conditions and be taking a whole pharmacy of medications, and those can interact with anesthetics in unpredictable ways.
It's like a big puzzle where all the pieces affect each other. We got to be super diligent about checking their meds list and watching out for potential interactions.
You got it. Now, since we're talking about potential complications, let's go back to malignant hyperthermia for a sec. Something every nurse needs to be ready for, even though it's rare.
Absolutely. Early recognition and quick action can be life-saving.
You're telling me. Remember, it's inherited, so family history is key during that pre-op assessment. If there's even a hint of it in the family, the anesthesiologist will be extra cautious and might even choose different drugs to avoid triggering it.
So not everyone is at risk, but for those who are, it's a big deal. What are the red flags we need to watch out for?
The classic sign is a rapid, unexplained fever, usually over 104 degrees Fahrenheit, but that's not always the first thing you see.
What else should we be looking for?
Early signs can include a jump in their end-tidal carbon dioxide levels, which we can track with capnography. Tachycardia, that's a rapid heart rate, and muscle rigidity, especially in the jaw or chest.
So it's like the body goes haywire and things escalate quickly. What's the treatment?
First thing, stop those anesthetic drugs immediately. Then cool the patient down fast. Cooling blankets, ice packs, even cold IV fluids. We also got to support their breathing and circulation with a ventilator and meds to stabilize their heart rhythm.
Oh, and there's that specific medication, dantrolene, right? Yeah. That's crucial for treating malignant hyperthermia.
Absolutely. Dantrolene is a muscle relaxant that works directly on the muscles, stops those uncontrolled contractions, and brings down the heat. It's the antidote, basically. Got to have it on hand wherever general anesthesia is being given.
Sounds like having dantrolene ready to go and a clear plan for dealing with malignant hyperthermia is essential in any OR.
You're absolutely right. A lot of hospitals even have special malignant hyperthermia carts with all the meds and equipment you need. And they run drills to make sure the whole surgical team knows exactly what to do if it happens.
So general anesthesia is a great tool, but it's not always the best option. Sometimes something less invasive, like moderate sedation, is a better choice.
That's true. Moderate sedation, sometimes called conscious sedation, it's a way to keep patients relaxed and comfy during procedures without knocking them out completely.
Middle ground again.
Yep. The goal is to reduce anxiety and pain, but keep them breathing on their own and able to respond to commands.
Good for things that aren't too invasive and don't need complete muscle relaxation.
Exactly. We use it a lot for colonoscopies, biopsies, minor surgeries, even some dental work.
What kind of drugs are we talking about here?
Usually it's a combo of meds, often a benzodiazepine like midazolam that calms them down and can cause amnesia, and an opioid like fentanyl for pain relief.
Amnesia, so they won't remember the procedure.
Sometimes, yeah. Benzodiazepines can do that, cause temporary memory loss, can be helpful for reducing anxiety. But remember, it's not guaranteed, so we always got to treat our patients with respect, even when they're sedated.
That's important. Easy to forget, they might still be aware, even if they don't remember it later.
Now, when you're using a cocktail of drugs like that, you got to be careful about interactions and adjust the doses. For example, if you're giving midazolam with an opioid, you might need to lower the dose of both to avoid oversedation or problems breathing.
Finding that balance, enough sedation and pain relief, but keeping them safe.
Exactly. And like any anesthesia, monitoring is key. We watch their vitals, level of consciousness, and breathing the whole time, even during recovery.
Now, before we get to local anesthesia, what about kids getting moderate sedation? Anything special we need to know?
Kids are different. Their bodies handle meds differently than adults. Got to be super careful with the dose, based on their weight and age. We often give it by mouth. Liquid forms of sedatives or pain meds makes it less scary for them.
Makes sense. Anything to make a medical procedure less terrifying for a child.
Right. And just like with adults, monitoring is super important. Vitals, consciousness, breathing, all of it.
What about sending kids home after moderate sedation? Anything specific we need to check?
Got to make sure they're fully alert, oriented, and can drink fluids without getting sick. Vitals should be stable, and they should be able to walk without help.
Basically, making sure they've bounced back from the sedation and are good to go home.
You got it. All right, time to switch gears and explore local anesthesia.
Local anesthesia, so versatile. Numb a specific part of the body, keep the patient awake.
It is, isn't it? And the drugs are fascinating. They block nerve transmission in a very specific area, so the pain signals never reach the brain. Unlike general, they don't touch consciousness, so the patient is awake and aware the whole time.
Awake, aware, but no pain in the target area. How does that work exactly?
Local anesthetics, they mainly mess with sodium ions. Sodium ions, they're essential for those nerve impulses to travel. The anesthetic blocks the flow of those ions, so the pain signal gets stopped in its tracks.
Like cutting the wires, so the message can't get through.
That's a great way to picture it. Now, there are two main types, esters and amides. They're metabolized a bit differently and have different chances of causing allergies.
So knowing the type helps us prevent and manage potential problems.
Absolutely. Esters, like procaine, they break down faster and are more likely to cause allergic reactions. Amides, like lidocaine and bupivacaine, they last longer and are generally considered safer when it comes to allergies.
Good to know. Now, giving local anesthesia, it's not always just a simple injection.
That's true. Depends on the procedure and where on the body we're working.
Probably the most well-known type is spinal anesthesia, the spinal block.
Spinal anesthesia, we inject the local anesthetic right into the cerebrospinal fluid that bathes the spinal cord. This numbs the nerves that carry sensations from the lower body, usually from the belly button down to the toes.
So it's perfect for surgeries on the legs or the pelvic area.
Exactly. Hip replacements, knee replacements, C-sections, anything down there.
Spinal anesthesia sounds intense. Are there any risks?
There are potential complications, like with any medical procedure, but usually we can manage them. One common side effect is a spinal headache. It happens if some cerebrospinal fluid leaks from the puncture site.
Ouch, that doesn't sound fun. What causes that, and how do you treat it?
Basically, when you lose some cerebrospinal fluid, the pressure around the brain and spinal cord drops. That can cause a throbbing headache that's worse when you're upright and better when you lie down.
It depends on your position.
Exactly. Treatment usually involves bed rest, drinking lots of fluids, and pain meds. In really bad cases, we might do a blood patch, which is basically using a bit of the patient's blood to seal the leak in the dura, the tough membrane around the spinal cord.
So spinal anesthesia is effective, but we got to watch out for potential side effects and monitor the patient closely.
Absolutely. Now, another regional anesthesia we use a lot, especially in labor and delivery, is the epidural.
I've heard about epidurals for pain relief during labor, but how are they different from a spinal?
Epidurals and spinals, they both numb the lower body. But with an epidural, we inject the anesthetic into the epidural space, the area around the dura mater, not directly into the cerebrospinal fluid like with a spinal.
So same target, different location for the medication.
Yep. And because of that, the numbness kicks in a bit slower with an epidural, but it lasts longer, which is great for labor.
So pretty versatile pain management during labor or after big abdominal or back surgeries.
Exactly. Now, moving away from the spine, we have nerve blocks, another popular regional anesthesia technique.
Nerve blocks, what are those and how do they work?
With a nerve block, we inject the local anesthetic near a specific nerve or group of nerves. Numbs a particular part of the body, could be an arm, a leg, even a specific spot on the face. We use it for all sorts of procedures, from minor stuff to more complex surgeries.
Sounds very precise. Minimize the numbness and potentially reduce side effects.
That's the idea. Because the anesthetic is more localized, there's less risk of it affecting the whole body, unlike with spinals or epidurals.
Are there different types of nerve blocks?
Oh yeah, tons of them. Each one targets a specific nerve or group of nerves. Femoral nerve block numbs the thigh and knee. A brachial plexus block numbs the whole arm.
So the choice depends on where the surgery is and what area needs to be numb.
Exactly. Now, another common type, especially for smaller procedures, is infiltration anesthesia.
What's the difference between infiltration and a nerve block?
Infiltration, we inject the anesthetic right into the tissues where we're going to be working, basically create a numb field within the surgical area.
So not about targeting specific nerves, more about numbing the tissues directly.
That's it. Infiltration is used a lot for closing wounds, removing moles, biopsies, that kind of thing.
I've had that before. Definitely makes those procedures more bearable.
Simple but effective. And lastly, we have topical anesthesia, the least invasive of the bunch.
Topical anesthesia, what's that?
That's when we apply the anesthetic right onto the skin or mucous membranes. Think of those numbing creams for burns or lidocaine spray to numb the throat before putting in a breathing tube.
So pain relief on the surface, no needles needed.
Exactly. Good for minor procedures or numbing a small area before something more invasive, like starting an IV or taking a blood sample.
Definitely less scary than a needle. With any local anesthesia, we got to be careful about allergies and sensitivities, right?
You're right. Always got to be thorough. Double check for allergies before giving any meds, especially anesthetics.
And we talked about how esters are more likely to cause allergic reactions than amides. So if a patient has a history of allergies to local anesthetics, we'd steer clear of the ester types.
Exactly. Minimize those risks. Keep our patients safe.
Now let's talk about neuromuscular blocking drugs. NMBDs. Powerful meds, paralyze muscles, even the ones we need for breathing. Got to be extra careful with these.
They are powerful, that's for sure. NMBDs, they're not technically anesthetics, but we use them a lot alongside general anesthesia during surgery. They're not for pain relief. Their main job is to relax and paralyze muscles.
Paralyzed muscles, that sounds kind of scary.
It can be, yeah. NMBDs are serious business. We use them in specific situations during surgery to make it easier to put in a breathing tube, relax those muscles, and prevent any movement. Especially important for those really delicate procedures where even a little twitch could be a problem.
Okay, so not for pain, but to create the best conditions for the surgery by keeping the patient's muscles still.
Exactly. The thing to remember is they paralyze everything, including the diaphragm, the main muscle we use to breathe. That's why mechanical ventilation is absolutely essential when we use these drugs.
Without a ventilator, they wouldn't be able to breathe at all. Really highlights the importance of clear communication and careful monitoring in the OR.
No kidding. There have been some awful cases where NMBDs were given by mistake without proper ventilation, and it didn't end well. So we got to be extra vigilant, make sure the patient is properly ventilated before, during, and after we give these meds.
You mentioned two main types of NMBDs, depolarizing and non-depolarizing. What's the difference, and how do they work?
All right, so the neuromuscular junction, that's where the nerve connects with the muscle fiber, where the muscle contraction happens. Normally, when a nerve impulse gets there, it releases this neurotransmitter called acetylcholine.
Acetylcholine, that's the signal for the muscle to contract.
That's right, it binds to receptors on the muscle fiber, sets off a chain reaction, and boom, the muscle contracts. Now, depolarizing NMBDs, like succinylcholine, they mimic acetylcholine.
So they bind to the same receptors and trick the muscle into contracting.
Exactly. But they bind much more strongly and hang on longer than acetylcholine does.
So it's like overstimulation, which leads to paralysis.
You got it. The muscle twitches and contracts at first, but then it gets tired and can't respond anymore, and that's how you get paralysis.
So that's the depolarizing type. What about non-depolarizing?
Non-depolarizing NMBDs, they work by blocking acetylcholine from binding to those receptors in the first place. They're like blockers, taking up those spots so acetylcholine can't get through.
Different mechanism, but same result. Paralysis.
Exactly. Each type has its pros and cons, and which one we use depends on the situation.
Are there times when one type is better than the other?
There are. Acetylcholine, the depolarizing one, it kicks in really fast within a minute, and it doesn't last very long, just a few minutes.
So good for emergencies when you need to put a breathing tube in quickly.
You got it. But succinylcholine can have some nasty side effects, muscle pain, and it can cause potassium to leak out of muscle cells, which can be dangerous. And it's also linked to malignant hyperthermia, which we talked about earlier.
Powerful stuff, but handle with care.
Absolutely. Non-depolarizing NMBDs like rocuronium or vicuronium, they're slower, take a few minutes to work, but they last much longer, anywhere from 20 to 60 minutes or even more, depending on the drug and the dose.
So better for keeping those muscles paralyzed during longer surgeries.
Right. They're also generally considered safer than succinylcholine. Fewer side effects and less likely to trigger that malignant hyperthermia.
So choosing between them depends on what's going on, how long we need the paralysis to last, and the patient's individual risks.
Exactly. Now, with NMBDs, it's really important to understand how that paralysis unfolds and how it wears off. It doesn't affect all muscles at the same time, you see.
So the smaller muscles, the ones that do those fine movements, they're usually the first to go.
That's right. Think about the muscles in the face, the eyes, the fingers. They're usually the first to get paralyzed. Then it moves to the bigger muscles, like in the arms and legs, neck, and torso. And lastly, the diaphragm, the one we need for breathing, that's affected.
Makes sense. The smaller, faster muscles would be more sensitive to those NMBDs.
Makes sense, yeah. And when the meds wear off, it goes in reverse. Diaphragm first, then the limbs, neck, and torso, and finally those smaller muscles in the face, eyes, and fingers come back online.
Pretty amazing how the body responds so predictably.
It is, isn't it? And knowing this is crucial for us nurses taking care of these patients, we need to be able to figure out how paralyzed they are, monitor their recovery, and anticipate their needs.
Speaking of monitoring, what are the key things we got to watch for when someone's on NMBDs?
Well, the biggest one is making sure they're breathing right. They can't do it themselves while those drugs are working, so we're monitoring their oxygen levels, their breathing rate, and those end-tidal carbon dioxide levels. We also got to keep an eye on their blood pressure, heart rate, and rhythm, because NMBDs can sometimes mess with the heart.
So it's not just about the ventilator. We're looking at their whole body, making sure they're stable.
You got it. And watch out for electrolyte imbalances, especially potassium. NMBDs can affect potassium levels, and that can cause problems with the heart and other things.
NMBDs, they're complicated, high-stakes meds. You really need to know what you're doing and understand how they affect the body.
No doubt about it. But when we use them the right way, with careful monitoring, they're incredibly useful for making sure surgeries go smoothly and safely.
Okay, so we've covered the main types of anesthesia and some of the key meds. Now let's talk about nursing care. Objectives 6 and 7 in the textbook, they want us to develop nursing care plans for patients going through anesthesia, whether it's general, local, or moderate sedation.
Perfect timing. We nurses, we play a huge role in keeping our patients safe and comfortable through the whole surgical experience, from the moment they're admitted to pre-op all the way to when they go home.
Let's start with the care plan for general anesthesia. What are the big things we need to think about and do in pre-op?
Pre-op, it's all about gathering info, assessing their health, figuring out any risk factors, and getting them ready for surgery, both physically and mentally.
laying the groundwork for a safe and successful procedure.
You got it. Starts with a thorough nursing assessment. Medical history, current meds, allergies, sensitivities, the whole 9 yards.
Looking for anything that could affect how they handle anesthesia or increase their risk of complications.
Absolutely. And a focused physical assessment, too. Really pay attention to their heart and lungs. Those are the systems most affected by general anesthesia.
Listening to their heart and lungs, checking blood pressure and pulse, making sure their airway is clear.
Exactly. And don't forget the neurological assessment. Level of consciousness, cognitive function, anesthesia can mess with those too.
What about the emotional side of pre-op? Anesthesia can be pretty scary for a lot of people.
Oh, absolutely. We got to address their fears and concerns, answer their questions honestly, and provide support and reassurance.
Just taking the time to listen and acknowledge their feelings can make a big difference in easing their anxiety.
It really can. And don't underestimate those little comfort measures. A warm blanket, dim lights, some calming music, those can go a long way in helping them relax.
It's about treating the whole person, not just the medical problem.
Exactly. Now, once they're in the OR, our role shifts to monitoring and keeping them safe during the surgery.
So, what are the most important things we're watching for when they're under general anesthesia?
Always, always the ABCs. Airway, breathing, circulation. Make sure that airway stays open, no obstructions. Monitor their breathing patterns and oxygen levels constantly. And keep a close eye on their blood pressure, heart rate, and rhythm.
Like a hawk, watching for any signs of trouble and ready to jump in if something goes wrong?
Exactly. We're their advocate in the OR, their voice when they can't speak for themselves.
What kind of things could go wrong during general anesthesia? How would we respond as nurses?
Well, there's always a risk of complications, but some of the common ones we see are hypotension, that's a drop in blood pressure, can happen because some anesthetics make the blood vessels relax. We'd be watching their blood pressure closely and be ready to give fluids or meds as ordered to stabilize it.
So we're looking for patterns being proactive.
Exactly. Catch it early, act fast, prevent bigger problems. Then there's bradycardia, a slow heart rate. Can happen with certain types of anesthesia, or if the patient has some heart issues. We'd be continuously monitoring their heart rate and rhythm and be ready to give meds to speed it up if needed.
Sounds like nurses in the OR need to know their heart meds really well.
Absolutely. We got to anticipate problems and know how to handle emergencies. Respiratory depression, we talked about that. General anesthetics slow down breathing. Can lead to slower rate, shallower breaths, even apnea. Our main job is making sure they're breathing well, whether that's helping the anesthesiologist with manual ventilation or watching the ventilator like a hawk. We're also checking those oxygen saturation levels and end-tidal carbon dioxide levels all the time, make sure they're getting enough oxygen and getting rid of carbon dioxide properly.
So you need to be really on top of things, really understand how the respiratory system works.
You got it. Then there's nausea and vomiting. Some folks get sick after general anesthesia. Could be the meds, or it could be related to the surgery itself. We always anticipate this and have antiemetics ready to go, as ordered, to prevent or treat it. And we position the patient carefully so they don't aspirate if they do vomit.
Aspiration. That can cause serious problems with breathing.
No kidding. And lastly, emergence delirium. Happens sometimes when people wake up from anesthesia, especially kids and older adults. They can get confused, agitated, restless, even have hallucinations. Our job is to keep things calm and reassuring, reorient them frequently, and make sure they're safe while they're coming back to reality.
Like guiding them back from that anesthesia fog.
Exactly. All right, so the surgery's done, anesthesia's wearing off, and we move into the post-op phase. You still got to monitor them closely, make sure they recover smoothly.
What are our main priorities in post-op?
Still the same.
Yeah.
Airway, breathing, circulation. We're also watching their level of consciousness, how much pain they're in, and if they're feeling nauseous.
Making sure they transition back to being awake and stable without any problems.
Exactly. And of course, pain management is huge in post-op. We got to anticipate their needs, give pain meds as ordered, and keep checking their pain levels to make sure they're comfortable.
Pain management is so important, makes a big difference in how well they recover.
You're telling me. So those are the general principles for post-op care. But there are some differences depending on what kind of anesthesia they had.
Right. The objectives want separate care plans for local and moderate sedation. What are the key differences there?
With local anesthesia, we got to pay close attention to where the anesthetic was given. Watch for bleeding, swelling, signs of infection. Also check how numb they are and make sure they don't put any pressure on that area until the feeling comes back.
Protect the area while it's numb. Help them understand they can't use it normally for a bit.
Exactly. And with moderate sedation, we're mainly focused on their level of consciousness, how well they're breathing, and if they're responding to commands. Make sure they're breathing okay, responding appropriately, and not having any bad reactions to the meds.
Finding that balance again, sedation without knocking them out completely.
Right. And once the procedure is over, we monitor their recovery carefully, make sure they're fully alert, oriented, and able to go back to their normal activities or go home safely with the right instructions and support.
Okay, time to test our knowledge. Let's go through some of those review questions from the textbook. Good way to see how much we've learned and what we still need to work on.
Sounds good to me. Always a good idea to put ourselves to the test.
First question. Why do we often add epinephrine to lidocaine, that common local anesthetic?
Right.
The choices are A, it calms the patient down, B, it reduces the risk of allergic reactions, C, it makes the lidocaine work better, D, it decreases bleeding in the surgical area.
The answer is D. It reduces bleeding in the surgical area.
Can you explain why?
Epinephrine, it's a vasoconstrictor, makes those blood vessels shrink. When we add it to lidocaine, it constricts the blood vessels in the area where we inject it.
Like a temporary tourniquet, less blood flow, less bleeding.
Exactly. Really helpful during surgery, helps keep the surgical field clear.
Makes sense. Next question. We got to figure out which patients are more likely to have complications from general anesthesia. Here's the list. A 79-year-old getting a hip replacement. B, a 49-year-old athlete who quit smoking 12 years ago. C, a 19-year-old with a history of substance and alcohol abuse. D, a 30-year-old in perfect health who's never had anesthesia before. E, a 50-year-old having outpatient laser eye surgery. So which ones are at higher risk?
The higher risk patients are A, the 79-year-old, and C, the 19-year-old with the substance abuse history.
Why are those two considered higher risk?
Older adults, like our 79-year-old patient, their organs just don't work as well as they used to, especially the heart, lungs, and kidneys. This can affect how their bodies process the anesthetic drugs, making complications more likely.
So age itself is a risk factor.
It is. And the 19-year-old, that history of substance abuse can really damage the liver, heart, and brain. That can make their response to anesthesia unpredictable and increase their risk of complications.
So it's not just about the surgery. We got to look at their overall health, any other conditions they have, and lifestyle factors that could play a role.
Exactly. It's about seeing the whole picture and tailoring their care to their specific needs and risks.
Okay, next question. We're looking for the best nursing diagnosis for a patient recovering from general anesthesia. The choices are A, altered urinary elimination due to vasopressors. B, decreased self-control due to anesthesia effects. C, altered safety with risk for falls due to decreased sensorium for several days. So, altered oxygenation due to the CNS depressant effect of anesthesia.
The best one here is D, altered oxygenation due to the CNS depressant effect of anesthesia.
Why is that one the most important?
Remember, general anesthetics, they slow down the central nervous system, including the part of the brain that controls breathing. This can lead to slower breathing, shallower breaths, even periods where they stop breathing altogether. So making sure they're getting enough oxygen is a top priority during and after general anesthesia.
Makes sense. Airway and breathing are always at the top of the list.
Absolutely.
All right, next one. What's the nurse's biggest concern right after surgery for a patient who had general anesthesia? The options are A, airway,
Yes.
B, pupillary reflexes, C, return of sensations, D, level of consciousness.
The most critical concern is A, airway.
Why is the airway more important than the other things?
As the anesthesia wears off, those breathing muscles, the diaphragm and the muscles in the throat, they can still be relaxed, which can block the airway.
So even though the surgery's over and they're waking up, the airway is still a major concern.
Exactly. We got to watch it closely, make sure it stays open, and be ready to act fast if they start having trouble breathing.
Suction any secretions, reposition them to open the airway, maybe even help reintubate them if we have to.
Absolutely. Airway management, it's a basic but essential skill for any nurse caring for post-op patients, especially after general anesthesia.
Okay, this next one is about a patient who's anxious about having a cardioversion procedure. They're getting moderate sedation with propofol, but they're worried about feeling pain during the shock. They ask, will I feel it? What's the best way to respond? A, the shock is too weak to feel. B, you'll feel it but won't remember. C, the meds will ease pain, and you probably won't remember the procedure. D, you'll get enough pain meds to block it completely.
The best response is C. The meds will ease pain, and you probably won't remember the procedure.
Why is that the best way to answer?
It acknowledges their fear, which is important, but it's also honest. Moderate sedation can cause amnesia, so they probably won't remember, but it doesn't completely block all sensations.
So it's honest and reassuring at the same time.
Exactly. And it's important to point out that the meds, like propofol, also have pain-relieving properties, so even if they feel something, it's unlikely to be painful.
So we're validating their feelings, explaining how the meds work, and reassuring them that they'll be okay.
You got it.
Now, for a question about those NMBDs, what's the correct order of muscle paralysis they cause? The choices are A, paralysis of small, rapidly moving muscles. B, muscle weakness. C, paralysis of limb, neck, and trunk muscles. D, paralysis of the intercostal and diaphragm muscles.
The correct order is B, muscle weakness, then A, paralysis of small, rapidly moving muscles, then C, paralysis of limb, neck, and trunk muscles, and finally D, paralysis of the intercostal and diaphragm muscles.
So it starts subtly, then gets more and more pronounced, ending with the muscles they need to breathe. Really shows why NMBDs are so tricky and need such careful monitoring.
For sure, we got to be on our toes and anticipate what the patient needs at every stage.
Last question before we move on. Besides a high temperature, what are some other signs of malignant hyperthermia that we need to be watching for during anesthesia?
The classic signs, along with that fever, are tachycardia, a rapid heart rate, tachypnea, that's rapid breathing, and muscle rigidity, that's stiffness, often starting in the jaw or chest.
So it's not just the temperature. We're looking for all these physiological changes that tell us something's really wrong.
Exactly. We got to catch malignant hyperthermia early because it can go downhill fast and become life-threatening.
Before we wrap up, I want to switch gears a bit and talk about the human side of anesthesia care. It's not just about the technical stuff. What are some things that you, as an experienced nurse, have found helpful in providing compassionate, patient-centered care to people going through anesthesia?
That's a great question. For me, it always comes back to the basics of nursing: communication, empathy, and really advocating for our patients. Anesthesia can be a very vulnerable time, physically and emotionally.
So we need to recognize that and treat them with compassion and understanding.
Absolutely. Take the time to listen to their fears, answer their questions honestly, give them reassurance and support. That can make their whole experience so much better. It's about seeing them as a person, not just a patient.
I agree completely. Building that rapport, explaining things clearly, addressing their fears, it all helps reduce anxiety and makes the whole thing less scary.
And during the procedure itself, it's all about vigilance. Watching those vital signs, noticing any subtle changes, being ready to act quickly if something unexpected happens.
And that vigilance carries over into post-op, too, making sure their pain is managed, monitoring their recovery, giving them clear instructions for when they go home. All of that helps prevent complications and makes the transition back to their normal life smoother.
And never underestimate the power of those little comforts. Repositioning them, adjusting their blankets, offering a cool compress, those things show you care and can really help them feel better.
Those little things make a difference, right? It's
Yeah.
about treating the whole person.
Exactly. Now, I want to highlight a few more key points from the textbook before we finish up. First, anesthesia. It's always changing. New drugs, new techniques, new technologies all the time. So we got to stay curious, keep learning, and stay up to date to give our patients the best care.
That's what makes nursing so great. It's always challenging us to learn and grow.
You said it. And never forget, patient safety is always number one. Anesthesia can save lives and improve quality of life, but it's not without risks.
So we got to be respectful of those risks, be vigilant, and always do everything we can to keep our patients safe.
You got it. That means being thorough in those pre-op assessments, double-checking meds and doses, watching our patients like hawks during the procedure, and anticipating problems before they pop up.
Being proactive, not reactive.
Exactly. And lastly, I can't stress enough how important teamwork and communication are in anesthesia care.
It's not a one-person show. It takes a whole team of skilled professionals working together, focused on the patient's well-being.
Absolutely. Clear, concise communication between the anesthesiologist, the surgeon, the nurses, everyone involved. That's key to making sure things go smoothly and the patient has a good outcome.
All right, let's take a breath and think about everything we've covered.
It's been a lot, but hopefully it's helped you understand anesthesia a little better. We went over the basics, different types, how the drugs work, potential complications, nursing care, the whole shebang.
And then we talked about the importance of treating our patients with compassion and understanding, because anesthesia can be a pretty tough experience.
It can. So as we wrap up this episode, I want to leave you with a question to think about. Think about your own experiences as nurses. Whether you've been doing this for years or you're just starting out, what are some strategies you've found that really work to keep patients safe and comfortable during and after anesthesia?
That's a great question to ponder. Anesthesia care, it's such a complex thing. It takes technical skills, critical thinking, and compassion.
Absolutely. It's finding that sweet spot between the science and the art of nursing. Remember, each patient is different, and their care needs to be individualized.
So, to all you nurses out there, think about your practice, share your insights, and keep learning and growing in this field.
Because at the end of the day, it's all about making a difference for our patients, keeping them safe, relieving their pain, and helping them get through this sometimes scary experience with dignity and confidence.
Well said. And that wraps up our deep dive into anesthesia. We hope you found it informative, engaging, and maybe even a little bit inspiring.
Until next time, stay curious, stay compassionate, and keep those vital signs strong. And we tackled those review questions. Good practice to test ourselves, make sure we're really getting it. Now, to wrap things up, I want to leave you with something to think about.
I love that. Keep those brains working. What you got for our listeners today?
Think back on your own experiences, as nurses, been doing this for years, just starting out, doesn't matter. What have you found that really helps keep patients safe and comfortable during and after anesthesia?
That's a great question. There's so much to anesthesia care. Technical skills, critical thinking, and compassion. You got to have it all.
It's true, finding that balance, the science and the art of nursing. Every patient is different. Their care needs to be different, too.
So, nurses out there, think about it, share your thoughts, and never stop learning.
Because in the end, it's all about our patients, isn't it? Keeping them safe, taking away their pain, helping them get through this. Anesthesia can be scary. We got to help them feel confident and like they matter.
Couldn't have said it better myself. Well, folks, that brings us to the end of our deep dive into anesthesia. Hope you learned a thing or two, had some fun along the way, and maybe even feel a little bit inspired.
Until next time, stay curious, stay kind, and keep those vital signs strong.